Lindy Roberts from the Australian and New Zealand College of Anaesthetists.
Thank you. It's a pleasure to present the perspective of the Australian and New Zealand College of Anaesthetists and its Faculty of Pain Medicine. Graham Campbell, in his invitation, said to me if I could think about where I thought, or where our college thought we would be in 5 years' time and how we were going to address the issue of revalidation and how to get there. And what I'd like to do today is actually give a brief overview of how ANZCA is supporting the professionalism of its fellows, particularly how we're building the foundations and tools for performance assessment to allow us. I think part of this is actually the change management and bringing our fellows along with us. Anaesthetists have been leaders in the fields of quality and safety and in the educational use of simulation. And I think that leads us to our vision to be a recognised world leader in training, education, research and in setting standards for pain medicine. The Faculty of Pain Medicine is the first of its kind. It's an interdisciplinary body involved in training and standards in pain medicine. So these are the things I want to talk about today, and I'll particularly stress, I think, the issues and challenges we've faced in engaging our fellows and trainees in the process of our new professionalism tools, particularly through our CPD program. We're a binational college. We have about 1,500 trainees and just over 5,500 fellows. All of our FPM fellows are dual trained in both pain medicine but also in another specialty, for example surgery, psychiatry, rehab medicine, neurology, addiction medicine or general practice. We train specialists with a general scope of practice and we accredit departments and not posts for training. One of the important things that's allowed us to look at our specialist tools and professionalism support is that we introduced a competency-based curriculum in 2013, and we've developed the ANZCA roles in practice, which are based upon the CANMEDs with permission. And that has given us some tools and concepts to actually take into our development of support for specialists. And I think it's also part of change management that our trainees will have come through a program where they are already using multi-source feedback and other workplace-based assessment tools, which will help us to actually have a future that allows us to support performance assessment. We're doing the same thing for pain medicine, hoping to have that implemented next year. We've also been involved in GP anaesthesia training for over 40 years, and that's in collaboration with the colleges of GPs, so the RACGP and the Australian College of Rural and Remote Medicine. Anaesthetists work, and all our members work in multiple practice contexts, and that really, I think, goes to the issues of scope of practice and the difficulty of a one-size-fits-all approach. We work not only in theatre locations, but in perioperative services, in off-site or out-of-theatre locations like radiology suites and ECT suites, and really with all sorts of dental and medical and allied health practitioners. So that in itself creates some challenges for us. We recognise that the context in which we are practising is changing, and I think the most interesting thing to me in the revalidation workshop that the MBA ran last year was the surprise that the consumer reps had when they found out that we don't currently do anything to ensure that we're fit to practice, or that's not a regular part of our current processes. We recognise also international developments in regulation, in CPD best practice, and of course also in medical education evidence and practices. We welcome the revalidation conversation. I think it's an opportunity really for colleges to get on the front foot and actually show leadership in terms of how we support the professionalism of our fellows and our trainees. I think we also need to acknowledge resource constraints, and that's already been mentioned, not only at a macro level but also at an individual practitioner level, and that goes to the issues of change management and supporting practitioners. I think there are also many opportunities in terms of existing technology and also existing governance and performance appraisal and management systems, which we do need to take advantage of. So these are some of the ways in which ANZCA supports the professionalism of its fellows. We have a code of conduct, and that requires that fellows remain up to date and participate in CPD, and we made CPD mandatory prior to it becoming a requirement of registration in Australia. We're in the process of finalising a professionalism tool, which is based on the one that David Waters presented this morning with permission from RACS, and I think this is an example of how the colleges can actually save themselves from reinventing the wheel by sharing some of their initiatives with each other. We also provide support for professional transition. So in 2014, we've introduced a reinvigorated transitional period between traineeship and specialist practice, and we call that the provisional fellowship period, and we're actually developing some resources to support that transition. And that includes senior trainees having to participate in the CPD program, so setting them up really for a lifelong learning and participation in CPD. We've long supported flexible training and practice, and we have guidelines around practice re-entry. Our IMGS assessment process benchmarks overseas graduates against our own CPD requirements, and also offers them participation in the CPD program as part of their assessment process. We have a complaints handling process, and we also provide advice to outside bodies in relation to underperformance of our members. We were always going to revise our CPD standard around about this time, and when the revalidation conversation was announced in late 2012, that was an additional impetus to us actually looking at revising our CPD standard and program, and we've just implemented our new standard. It has a patient care focus, and I think most importantly, some of the performance practice evaluation activities actually increase the visibility to our patients that we're actually taking part in this process through asking their opinions about the performance of their anaesthetist or their pain specialist, contributing to audit and to multi-source feedback. It's based on the same ANZCA roles in practice that we use in our curriculum, and that allows continuity across the spectrum of practice. It also uses best practice principles and continuous improvement. It has a triennial requirement as well as a minimum annual requirement, and it's flexible for individual scopes of practice. It uses smart technology, and I'll show you that shortly, and also has a statistically validated verification process. There are anaesthesia and pain medicine versions of a single standard, and it has 3 compulsory categories. The first of these is practice evaluation, and this requires the practitioners to look at their own practice using one of 4 tools which are listed there on that slide. And we've looked to the literature to provide us with tools that are validated for the anaesthesia and for pain medicine practice to make sure that we're addressing the particular vagaries, I guess, of our practice. For example, a tool that you use in general practice where you have a continuity of care would be completely inappropriate for an anaesthetist who may only see the patient pre and immediately preoperatively, as well as look after them intraoperatively. We also have a knowledge and skills category which combines all the traditional learning activities that are typically more CME related. And finally, acknowledging that anaesthetists are experts in crisis management, we have a new compulsory emergency responses category which incorporates the key crises that we meet, like can't intubate, can't ventilate, advanced life support, anaphylaxis and massive blood loss. And there's capacity for those that are non-proceduralists to not complete this particular category. So I think in terms of the Klaus levels that we saw this morning, we're moving away from level 2 towards more of level 3 and level 4 in terms of our categories within our program. I think central to getting clinicians on board is to have a good technology solution, and this is our CPD portfolio system dashboard, which allows the practitioner to see how they're measuring up against the required standard in terms of each of the particular categories. It also allows them to see whether they've done the requirements of the program, such as their plan and also their evaluation at the end. So there are strong reflective components within this program. We also have incorporated automatic recognition of college-related and college-run events, and that really will also help, I think, practitioners to see this as a very streamlined process. We've also, in our handbook, provided guidance to assessors for things like peer review practice, and we also have templates for consent and issues such as mandatory reporting, so that the practitioners are well informed about how the process will work, what's the role of the reviewer and the reviewee, and what are their requirements in terms of the regulatory body's particular standards. I think engaging fellows and trainees is really key to the success of any new system, and it's really one of our biggest challenges. Some of the things that we find is that there's a growing awareness, and it's fair to say a lot of anxiety and some scepticism about the whole process of revalidation, particularly in terms of international developments. And I make no judgment about those things, but I really mention them to say that they really do need to be addressed for the general body of clinicians out there. Particular questions that I find are, what's the justification? Is this going to be overly onerous? Will it just deteriorate into a process-driven tick box exercise? And what's the cost going to be? So some of the approaches that we've taken is that we've actively involved our fellows in shaping this. We've surveyed them to see what they think about the changes that we were proposing to introduce. And it's interesting that we have found that they think things such as having to demonstrate that they can undertake advanced life support, they see as very reasonable. But they do worry about how they're actually going to access those courses. So one of the things that we've done is we've set up a system of recognising course providers in such a way that people can access the courses locally rather than having to do any formalised course, or certainly any course that's run by the college. We've also tried to make our categories and our approach meaningful to clinicians. We've integrated where we can with existing systems, and we've tried to make sure that we've adequately resourced it with supporting templates and tools. So I guess the answer to Graham Campbell's question about where we see this in 5 years' time is that we're working to lay the foundations initially by strengthening our CPD program, introducing practice evaluation components that look specifically at the practitioner's own practice, that acknowledges the importance of emergency responses in our roles as specialists, that provides feedback from patients and other team members, and also develops tools to enhance professionalism. I welcome the conversation about the future. I think it has to focus on patient care and adding value to patient care, and it needs to actively engage clinicians in the ways that I've mentioned. Thank you.